Struggling with nursing pharmacology? Would you like a resource you can put in your hands? You're not alone. If you want to understand medications instead of just memorizing them, check out the MedEd 101 Guide to Nursing Pharmacology on Amazon. Written by a board-certified clinical pharmacist, this book breaks down high-yield drug concepts, clinical pearls, and real-world examples that actually stick. Perfect for exams and the bedside. Whether you're in nursing school or already practicing, this guide helps you build confidence with medications fast. You can find a direct link to the 233-page book right now at meded101.com/nurse. That's meded101.com/nurse. In this section, I'm going to cover direct oral anticoagulants. They are often referred to as DOACs. All right, so let's dig into DOACs, and then I'll get into the individual agents. So from a broad, higher-level view, the mechanism of action of direct oral anticoagulants, they inhibit the action of factor Xa. So there are a bunch of different factors that are important and that are necessary to be around and active for the formation of blood clots and that physiological process. With these medications, we block the action primarily of factor Xa. Okay? So by not having that around, we are going to inhibit the coagulation cascade. Now, the biggest advantage, historically, we've used warfarin for blood thinning purposes. The biggest advantage of the DOACs, well, two big advantages, I would say. Lower risk for drug interactions. So warfarin has to be monitored for that very, very closely. And there are some interactions with DOACs, don't get me wrong, but they're less, definitely, than warfarin. The other big perk, especially for patients, and I could guess maybe the healthcare team too, we don't need to do, every other week or monthly INRs like we do with warfarin. So those INRs are drawn to make sure the blood is appropriately thinned, if you will, to make sure that we're preventing clots and those type of things. These DOACs have been studied to where it's a standard dose for most patients, with some exceptions. A few reasons I'll just mention briefly why you might not choose a DOAC over warfarin. DOACs are preferred in the guidelines at this point for most conditions, not all, but most. So you will see these more and more compared to the use of warfarin. But if you've got a patient that's super stable on warfarin, they've done really well, they're doing okay with it, they're fine with the lab checks, that's maybe a patient where we, at least we'll have that discussion, the risk versus benefit of switching them to a new medication when they seem to be doing really well on what they're taking. Prosthetic heart valves, prevention of clots in that setting, we don't have the evidence for DOACs like we do for warfarin. And then cost and insurance. So the direct cost of these medications is significantly greater, which warfarin is older and generic and cheaper as far as the direct medication. Now, when you factor in lab work and other things, that cost difference may start to kind of wash away. And then provider comfort preference, if the provider, for whatever reason, feels like warfarin is the best choice for their specific patient, you may see that utilized in that setting too. All right, let's get into the individual agents. So apixaban, probably one of the biggest downsides of apixaban versus other agents is it is dosed twice daily. Some of the other ones, particularly I guess just rivaroxaban, we can get by with once daily dosing. There are some dosage adjustments based upon kidney function and weight and age. So as that patient gets older, or as we're maybe experiencing bleeding and other adverse effects, thinking about a dose reduction would be a good thing to prompt the provider about potentially. We do have different dosing for treatment versus prophylaxis at times. And then again, we've got lower dosing based upon prophylaxis as well as age, creatinine, and weight, which you can see listed there. Again, lower risk of drug interactions than warfarin, but there are some. So CYP3A4 and P-glycoprotein inhibitors, we do have a few interactions there. As far as tolerability, adverse effects, I haven't had too many patients complain about it. With that said, obviously the biggest risk is bleeding. That's pretty much across the board with any anticoagulant, and that risk can be increased by other medications. So if you got a patient on aspirin, if you've got a patient on a P2Y12 inhibitor like clopidogrel, that risk for bleeding goes up and up and up. One of the most common ones that I strongly encourage you educate your patients about is over-the-counter use of NSAIDs. Okay, these can, kind of create that direct insult to the GI tract and potentially contribute to an ulcer. And NSAIDs also, so that's like ibuprofen, naproxen, some of those over-the-counter NSAIDs especially, we got to pay attention to that. Those can also inhibit the action of platelets, which would enhance the patient's risks of bleeding. All right, next medication, rivaroxaban. Once daily dosing, we do have those similar interactions, CYP3A4. The once daily versus the twice daily, that's probably the biggest claim to fame. Most will prefer apixaban because of the evidence that we have with that medication, but you'll see a fair amount of rivaroxaban as well. Again, use in DVT prophylaxis, and trying to prevent those strokes with atrial fibrillation as well. Edoxaban, I definitely see a lot less of this. We actually have a warning if the patient's creatinine clearance is above 95 mils per minute. So creatinine clearance, again, that's a measure of kidney function. So if they have a very high level of kidney function, there is a boxed warning that this medication won't be as effective and the risk for stroke may go up there. It is once daily dosing, renal function adjustments there, and again, those interactions still do exist. I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the MedEd 101 Nursing Pharmacology Review course. Dabigatran or Pradaxa, this is actually a direct thrombin inhibitor, slightly different than some of the other DOACs. GI bleed risk in patients over the age of 75. It is twice daily dosing as well. Because of those two factors, I've been seeing definitely less and less Pradaxa. Now let's talk about warfarin. Warfarin, common indications, again, similar to the DOACs. We got atrial fibrillation, DVT-PE, but we've got target goal INRs that we monitor for. So that's the biggest difference, I would say, with warfarin versus apixaban and the DOACs. We'll probably check a hemoglobin CBC periodically just to make sure that we're not getting anemic or there's no blood loss or anything. But that's not going to be as frequent as an INR, for example. We may alter those goals. Most patients are going to have a goal of 2 to 3. This is always a great thing to do with your providers, making sure that the medical record has a clear goal INR. Okay, that's an important thing to do. If they have prosthetic heart valves, that goal may be higher, and we typically target, the evidence says, 2.5 to 3.5 for the INR. So again, understanding the indication and making sure we're getting that goal target can kind of help keep the whole healthcare team on the same page. And again, we may adjust those goals based upon bleed risk, fall risk, those type of things, which can certainly increase the risk for catastrophic bleed for a patient. Pharmacokinetics, not going to go into this a ton, but we do have a bunch of drug interactions. I would say if you've got a patient that ever takes an antibiotic, I would definitely ask and inquire, should we check an INR once these antibiotics get going, just to make sure that that's all stable, because those levels can definitely fluctuate. And you can see metronidazole, Bactrim, quinolone antibiotics can sometimes do it. So there's definitely lots of antibiotics that may contribute to a fluctuating INR there for sure. Inducers, so we've got a medication like carbamazepine that can be used for seizures and bipolar disorder. We've also got OTC herbal medication like St. John's wort. These can actually stimulate the enzymes to work faster, and that would actually cause warfarin concentrations to go down, which would actually cause the INR to go down as well and potentially be subtherapeutic and put our patients at risk for a stroke or blood clot. All right, adverse effect profile, bleeding. That's pretty easy. Any type of anticoagulant, number one adverse effect is going to be bleeding. There is a rare adverse effect called purple toe syndrome, and this is due to giving too much warfarin initially. Okay, so basically what's called a loading dose of warfarin. And it's painful purple lesions on the toes and sides of the feet. So with that said, warfarin, its onset of action is slow. So if we need anticoagulation quickly, we're going to typically turn to heparin or Lovenox, and or potentially one of the oral anticoagulants that work a little bit quicker. So warfarin does take a little time to get that INR up to goal, usually in the period of a few days up to a week or two to kind of get stabilized. And here I kind of point that out. I've got a few specifics on some of the clotting factors and their half-life, and warfarin affects all of these, and because of that, you kind of get a little bit more of a variable response, and getting that INR settled can take a little bit of time. That's basically what I wanted to point out here. All right, causes of INR variation. So here's the big issue with warfarin. We got to obviously have patient adherence, and that's true of the newer anticoagulants as well. But diet can play a huge role in affecting warfarin, and specifically we've got vitamin K. So vitamin K is actually given as a potential antidote to warfarin to reduce its effects. But here's the deal: if patients increase their intake of vitamin K, that could cause the warfarin action to go down, and it could cause the INR to go down. So that's a big problem. If we have patients that come in and their INR's out of whack from where they normally are, look at that diet, look at that adherence. Those are the first two steps. Next step, keep an eye out for drug interactions, any changes there. And then rarely, you may have hepatic impairment. Heart failure can change kind of the fluid status and the concentrations and, how warfarin is eliminated and metabolized. So CHF exacerbation might affect INR. And fever is another one an infection that may cause some fluctuation there. Dose adjustments, again, most patients we're going to target that goal INR range of 2 to 3. The aggressiveness of the dosing is based a little bit on the INR. Standard is usually 10 to 15% dose adjustment there. In most cases, when we've got an INR above 4, so that would indicate really, really thin blood, and if that patient falls, if they bump themselves, whatever the case may be, scratches themselves, they're going to be at significantly greater risk for bleeding. And so holding the dose, INRs of greater than over 5, that's getting to be a much even more serious type of situation. So we're definitely holding warfarin, potentially giving vitamin K, and obviously monitoring that INR closely. So here's that vitamin K. So if we've got an elevated INR, 4, 5, 6, and we've got bleeding, we're giving vitamin K likely for sure. INR over 9, so getting close to that double digits. Vitamin K is probably coming out in that situation as well. Keep in mind, vitamin K, it is an antidote, but it takes a little while to work. So patients are still going to be at risk for a while, even after you give that vitamin K. We can also, for severe bleed, we can do transfusion. In that INR 5 to 9 range, it's probably up to kind of clinician discretion whether we're going to give vitamin K there or not, depending upon, patient situation and all those type of things. Hey, nurses and nursing students, want to reinforce pharmacology without boring old flashcards? Check out the Nursing Pharmacology Crossword Puzzle book from MedEd 101. It's an Amazon bestseller. It turns drug classes, mechanisms, side effects, and high-yield facts into fun, brain-boosting puzzles that help you remember what matters most. With over 2,000 questions and clues, it's perfect for study breaks, group review, or solo practice. This book makes learning pharmacology engaging. Grab your copy and start mastering meds in a way that's actually fun. Find it now at meded101.com/nurse. That's meded101.com/nurse.